Please be ready with your talk.
Very good morning. I'll be talking about the understanding of the Pentagram. So this is one of the first maps, and one of the most commonly looked at maps is of course the 4 maps refractive. The first thing we do is to make sure it's the right person, it's the right eye, and the right exam that we are looking at. The next thing to look at is the quality specification. And the OK here indicates that it's a good quality scan. If there is a yellow or a red indication in the box there, that means the quality of the scan is questionable. And next we look at the color scale. So here you can see it's 2 diopter steps. That means we might miss subtle changes in the topography in such a case. So we should look at the color scale as well and see how much of a gradient there is. Then is the axial curvature map that we look at most commonly, and this gives us an idea of the topometric pattern of that particular patient. Then is the front elevation, which again this is where the concept of the best fit sphere comes in. So this is anything above the best fit sphere is considered an elevation and has a positive value. Anything below that is a depression and has a negative value. So anything above 12 on the front elevation is considered suspicious, and anything above 15 is quite likely of ectasia. And there again, the back elevation, which is again relative to the best fit sphere, which is calculated according to the radii of that particular surface. So this more than 17 is considered suspicious again. And then we have the pachymetry, which gives us an idea of the thickness of the cornea and if there is any pattern of localized thickness or if it's an overall diffuse thickness of the cornea. Then we have the various metrics, and we can measure and we can really see exactly what the keratometry readings and other parameters are. So for example, here we have the axial curvature map showing significant inferior steepening. It's a decentered cone here, and you can see this is corresponding with the front elevation and the back elevation, and again thinning of the cornea as seen on the corneal thickness map. And here we have the steep K, which is about 50. So this is of course a case of keratoconus. Now here we have the typical crab claw pattern, and front elevation seen inferiorly, corresponding with a back elevation inferiorly, and a thinning which is present paracentrally. Again, a steep K of 50.7 diopters. This is a case of pellucid marginal degeneration. The other map that we look at very commonly is the Bell and Ambrosio enhanced ectasia display. So this shows the elevation map here. What it does is, when it calculates the best fit sphere, it excludes the central 4 mm, and that allows us to pick up ectasia with more sensitivity. So this is a map which shows the best fit sphere being calculated taking into account the ectatic part of the cornea as well. And this is a best fit sphere which excludes the central 4 mm of the ectatic part. So this is much more sensitive in picking up such changes. And so we have the elevation map in the BAT-D display, we have the exclusion map, and then we have this difference map. So you can see here there is a front elevation that has been picked up which might have been missed otherwise. Then we have the corneal thickness spatial profile, which tells us how the thickness of the cornea varies at different zones. The percentage thickness increase, which shows how the thickness is increasing from the center to the peripheries. And then we have these boxes, which I'll just talk about. So we have the progression index. The progression index looks at the progression from the thinnest point to the periphery all along at every 1 degree meridian along the complete 360. So the normal value for this is about 0.91. And here are the 5 boxes which show the front elevation, the back elevation, pachymetry progression, the thinnest point of the cornea, and the displacement of the thinnest point. So this tells us how many standard deviations away from the normal are the various parameters in this particular patient. So anything above 1.6 standard deviations comes with a yellow box. With more than 2.6 standard deviations comes with a red box. And the final D that we see here is based on regression analysis and gives an overall value of the map of this particular patient. So all of this helps us detect ectasia early. Another important map is the topometric KC staging map, which has the Bellin ABCD keratoconus staging, which is being highly talked about currently, and also tells us the asphericity values in different zones and has certain indices that we can look at for early detection of ectasia. These include the index of surface variance, the index of height asymmetry, index of vertical asymmetry, index of height decentration, the keratoconus index, center keratoconus index, the minimum radii, and based on this it gives a topographical keratoconus classification. So another important problem that we have is IOL power calculation in patients with keratoconus. So for that, what we have an important feature in the Pentagram is the holiday EKR detailed report. So this gives us the equivalent K readings in different zones of the cornea. So this we see is the equivalent K readings in different zones. This is centered at the pupil. Then we have the graph which compares various parameters. This is the histogram which shows the relative frequency of the equivalent K reading at different zones. And this is the EKR 65% mean which we commonly use, the value that we use commonly. And here is the power map. So this you can see here, it's a single peak, but it has a plateau. Okay, so this is a histogram which has a single peak but has a plateau. You can see the standard deviation is extremely high. So this is a cornea which is where the power is not very well localized. So we would not prefer going for a multifocal IOL in this case. And these EKR 65 readings are quite useful in using in the ACRS online calculator in post-refractive cases. So that gives us a much more accurate IOL power calculation. Here again, this is the cataract pre-op map, which gives us the total corneal refractive power, which is based on Snell's law and takes into account the refractive index of the anterior and the posterior corneal surface, and gives us also the total corneal spherical aberration. So based on this, we can choose whether we want to go for a positive aspheric, a spherical IOL, a zero aspheric IOL, or a negative aspheric IOL, depending on the pre-existing spherical aberration of the cornea. So here also this can be used. I'll just quickly brush through. This can be used for IOL power calculation with the Holiday 2 formula. This is the Pentagram nucleus staging, which gives us an idea of the opacity of the lens. Here is the corneal densitometry, which tells us about the haze of the cornea at different zones at different levels. So here is the table which shows us how much haze is present. This is in grayscale units, and this can help us monitor our response to cross-linking and TPRKs and see how much haze is present in the cornea, or to look at the scarring of the cornea. Thank you.
Sorry. Good presentation, Dr. Tushar. There are 14 speakers today, so let's restrict to 6 minutes talk. Okay, please. One question, just 30 seconds probably. Sure. Anything addition to this nowadays? Pentagram plus?
What we most commonly use is the EKR map, and we commonly use the corneal densitometry map. These are the maps in addition to, of course, the routine maps that we commonly use.
I think Corvis has come attached to it now.
Yes, Corvis has come attached to this, so that gives us a Corvis biomechanical index and a tomographic biomechanical index, which is more sensitive because the tomographic biomechanical index takes into account the topography as well, which is from the Bell display. So that is an additional important feature that we have, where the Corvis and Pentagram have been integrated now. So that tells us about topography, biomechanics together, rather than looking at them as independent entities.
Thank you.
Thank you.
Dr. Arun